I'm Dr. Jonathan Blake, a geriatric physician specialized in clinical neurology, with over 25 years of experience guiding adults and seniors on their journey to better health. And today, I urgently need to speak with you. Every 6 minutes, an adult over the age of 60 suffers a stroke, an event that, in most cases, could have been prevented. Behind these alarming numbers are real faces, families, and interrupted stories. A grandmother who will no longer tell bedtime tales. A father who will never again walk through his garden. A husband who no longer recognizes his wife. These lives are not lost suddenly. They fade in silence, often fueled, day after day, by decisions that seemed harmless, especially when it comes to the medications we take. In recent years, rigorous research has uncovered a truth that few want to face. Certain common medications, often prescribed with the best of intentions, are deeply linked to an increased risk of stroke in older adults. We're not talking about obscure or experimental substances. We're talking about drugs that may be in your drawer, part of your routine, and that you assume are safe simply because they were prescribed by a professional. And yes, they were. But what most people don't know is that the brain of someone over 60 reacts very differently to certain substances. The same dose that is tolerable at 40 can become a dangerous trigger at 70. And it happens silently, gradually, and without warning. Before I reveal which 4 medications pose this danger, and what safer alternatives you should discuss with your doctor, I need to explain what really happens during a stroke. To do that, imagine for a moment that your brain is like a living, bustling city. Your nerve cells are the houses, the buildings. The arteries that carry blood are like highways, transporting oxygen and nutrients, the fuel that keeps everything running. A stroke occurs when that traffic is abruptly halted. And there are 2 main ways this can happen. The first, and most common, is an ischemic stroke. A blood clot, like debris blocking a main avenue, prevents blood from flowing. Deprived of fuel, that region of the brain begins to die within minutes. It's like a sudden blackout in an entire city block. The second type is a hemorrhagic stroke, when one of those pipes bursts and blood floods the brain in a chaotic, destructive manner. In both cases, the results are devastating. Speech loss, paralysis, mental confusion, or even death. Now imagine this brain not as a young modern city, but as an old metropolis, rich in history, wisdom, and beauty, but with more fragile structures, more sensitive systems, and an urgent need for careful maintenance. This is the brain of an elderly person, and it does not respond to medication in the same way a younger body does. Many substances that work well in younger adults can have devastating side effects in brains already dealing with natural aging, reduced blood flow, and the accumulation of silent inflammation. That's exactly why we're here today. Over the next few minutes, we'll open, metaphorically, the medicine cabinet in your home. We'll put a magnifying glass on 4 types of medications among the most commonly used by seniors, and which hide dangerous traps for the aging brain. And we won't just talk about the risks. We'll also discuss real, safe, and effective alternatives. Because no one should have to choose between living with pain and living at risk. And you have the right, and the responsibility, to ask the right questions, seek updated information, and protect your health with clarity and intention. What we're about to discuss may save a life. It may prevent a loved one from losing mobility, or from spending the rest of their life unable to communicate. Medicine can no longer be a one-way street where you're simply told what to do. Today, knowledge is your greatest weapon. And I'm here to give you that knowledge. Clearly, directly, and responsibly. You don't need to understand technical terms or interpret scientific articles. I've done that for you. And what I found is, at the very least, alarming. For decades, we've treated chronic pain, urinary issues, inflammation, and behavioral changes in older adults with medications that work in the short term, but carry serious risks when used long-term or in people over 60. What's even more concerning is that many doctors don't even realize the connection between these medications and stroke. Not out of bad intention, but because medical training often doesn't keep up with the speed of scientific discovery. And that's why you need to take control of your health. From this point on, we'll dive into these medications, one by one. We'll explore how they work in the body, what side effects they specifically pose to the aging brain, and, most importantly, what can be done to treat the same issues without putting your life at risk. The first one on the list is likely a familiar name. You've probably taken it, have it at home, or know someone who uses it every day. It seems harmless. But when combined with age, time, and other silent conditions, it can become one of the main triggers for a stroke. Let's talk about it now. The first group of medications we need to address is so common that most people don't even consider it a risk. I'm talking about non-steroidal anti-inflammatory drugs, also known as NSAIDs. Names like ibuprofen, diclofenac, and naproxen. They're sold over the counter at any pharmacy, taken without prescriptions, recommended by friends, and often used as part of the daily routine by people living with chronic pain, such as arthritis or osteoarthritis. And it's precisely this normalization that makes them so dangerous. For many adults over the age of 60, these medications are seen as indispensable allies. A sore knee, a stiff back, a muscle ache, and there goes the pill. It relieves the pain, and it works. But what most people don't know is that continuous use of NSAIDs poses a significant and direct risk to the cardiovascular system, and especially to the brain. And the reason is not one single isolated side effect. It's a combination of simultaneous mechanisms that together create the perfect storm. The first mechanism is increased blood pressure. NSAIDs cause the body to retain more sodium and water, which increases the volume of circulating blood. Picture your arteries as a garden hose. If you increase the volume of liquid inside it while also making the walls of that hose more rigid, the result is steadily increasing internal pressure. This rise in pressure is silent, progressive, and unfortunately, the number one risk factor for stroke. All it takes is one spike, one rupture, one clot, and the consequences can be irreversible. The second mechanism directly affects the kidneys and platelets. Kidneys, which already work more slowly with age, are extremely sensitive to the effects of NSAIDs. Their ability to filter declines, which further worsens fluid retention and blood pressure control. At the same time, these anti-inflammatories interfere with platelet function, the very cells responsible for clotting. This interference destabilizes the body's internal defense systems, making it more prone to form clots where it shouldn't, such as inside a brain artery. But there's a third, even more insidious factor: the promotion of atherosclerosis. Long-term use of these medications triggers chronic inflammation in the inner lining of the arteries. That inflammation acts like sandpaper, damaging the inner vessel walls. In these damaged areas, cholesterol builds up more easily, forming plaques that, over time, can rupture and lead to fatal blockages. In other words, without realizing it, what started as pain relief is slowly, day by day, laying the groundwork for a stroke. Let me illustrate this with a real case I followed closely. Carlos, 68 years old, retired, careful with his diet, passionate about gardening. He had knee osteoarthritis and had been taking diclofenac twice a day for over 5 years. "It's what allows me to get out of bed," he said. His blood pressure was slightly above ideal, but nothing alarming. The problem was that over time, his kidneys began to lose function, his blood pressure rose further, and arterial stiffness intensified. One day, while watering his flowers, Carlos felt sudden dizziness, dropped the hose, and realized he couldn't move his right arm. The diagnosis: ischemic stroke. The immediate cause: a blood clot. But the trigger had been built, tablet by tablet, over years of what seemed like harmless use. So what can be done? Living in pain is not an option. But neither is living at risk. The first step is understanding that stopping any medication on your own can be even more dangerous. Never stop taking any drug without first consulting your doctor. The right approach begins with an honest conversation. You should ask, "Doctor, is this anti-inflammatory really the safest option for me, considering my age and blood pressure history? What is the lowest effective dose I can take, and for how long?" The good news is that there are alternatives. In many cases, acetaminophen, paracetamol, may be enough for mild to moderate pain and has a much safer cardiovascular risk profile. Another effective option is topical anti-inflammatories, such as diclofenac creams or gels, which act locally and reduce systemic exposure. In addition, pain management should be multidisciplinary. Physical therapy, acupuncture, tailored exercises, hot and cold compresses. All of these can help reduce dependence on oral medications. The key is strategy. It's not about eliminating pain at any cost. It's about addressing its causes with intelligence and care. Relief that comes too quickly and without oversight can end up costing far too much. Knowing this gives you an advantage. You can now ask the right questions and, by doing so, protect your brain, your heart, and your independence. When we talk about stroke risk, almost no one thinks about medications for urinary incontinence. And perhaps that's precisely why this is one of the most overlooked dangers in the daily lives of older adults. If you or someone close to you has ever experienced episodes of urinary urgency, involuntary leakage, or an overactive bladder, it's very likely that a doctor prescribed an anticholinergic drug. And this is where the dangerous connections begin. Connections that urgently need to be understood. Anticholinergics such as oxybutynin, tolterodine, and solifenacin are widely used to treat urinary symptoms. In many cases, they provide almost immediate relief, which gives the impression that they are completely safe. But what few professionals explain is that these medications directly interfere with a substance called acetylcholine, a neurotransmitter that is vital for brain function. And that is where the real danger lies. Acetylcholine is like an elite messenger within the nervous system. It plays a key role not only in muscle contraction, including the muscles of the bladder, but also in attention, memory, learning, and the regulation of cerebral blood flow. When you block that messenger, the impact can be devastating. And worse, that impact is usually gradual, silent, and easily mistaken for normal signs of aging. Numerous studies have shown that continuous use of anticholinergic medications is associated with a significant increase in the risk of cognitive decline, confusion, memory lapses, and even dementia. Many patients begin to report episodes of drowsiness, difficulty concentrating, frequent forgetfulness, and a sense of mental slowness. And unfortunately, these changes are often attributed to aging, when in fact, the brain is being directly affected by the medication. But the connection with stroke goes even deeper. Acetylcholine also plays a critical role in the ability of cerebral arteries to dilate when the brain needs more oxygen. When that mechanism is blocked, blood flow to certain regions of the brain can become insufficient. This creates vulnerable areas that, under stress or pressure, may fail, triggering ischemia or small strokes. Additionally, the side effects of these medications, such as dizziness upon standing, sedation, and drops in blood pressure, are direct risk factors for accidents and circulatory collapse, especially in more sensitive brains. I clearly remember the case of Marta, 75 years old, a widow, active, lucid, and proud of her independence. She began experiencing episodes of urinary urgency that caused her to avoid leaving the house. After seeking medical guidance, she started taking oxybutynin. In the first few weeks, the improvement was clear. She returned to shopping, resumed short walks. But little by little, her daughters began to notice subtle changes. She would forget simple words, confuse times, and became more drowsy during the day. One day, as she got up from the couch, she felt intense dizziness, staggered, and collapsed. She had suffered a transient ischemic attack, a warning sign that something more serious could happen. What doctors later discovered was that the medication had played a direct role. In a situation like this, the answer should never be to abruptly stop treatment. That can cause rebound effects, especially with medications that act on the nervous system. The decision must begin with information and dialogue. The first step is to check whether the medication being used has anticholinergic properties. If it does, it's essential to bring that information to the doctor and discuss safer alternatives. Fortunately, there are now more modern options that don't interfere with acetylcholine. The so-called beta-3 agonists, such as mirabegron, work differently and have a much more favorable safety profile, especially in older adults. In addition, non-drug approaches have immeasurable value. Pelvic floor strengthening exercises, such as Kegels, are extremely effective. Creating regular bathroom schedules, avoiding caffeine, alcohol, and soda, and adapting fluid intake throughout the day can make a huge difference. Treating incontinence is necessary, but it must not come at the cost of your cognition, your independence, or your brain health. The hidden risk of these medications lies in the lack of awareness. And now that you know, you have both the right and the responsibility to seek a safer solution. The human brain is a gift, and preserving its clarity, memory, and functionality must be a top priority in any treatment plan, especially after the age of 60. Among the most powerful, and at the same time, most dangerous medications for the aging brain are systemic corticosteroids. Drugs like prednisone and dexamethasone are true shock weapons of modern medicine. And with good reason. They save lives. They are essential in respiratory crises, severe allergic reactions, and autoimmune diseases. Within hours, they can control inflammation that might otherwise spread rapidly throughout the body. But it's precisely that power that must be treated with respect. When used continuously, without a transition strategy or proper protection, they become extremely harmful agents to both the cardiovascular and neurological systems. Corticosteroids act on multiple systems at once. They're not single-target drugs. They interfere with hormones, metabolism, immunity, blood pressure, blood sugar, and cholesterol. Their systemic action is intense. And in elderly individuals, who are more fragile and often dealing with multiple comorbidities, this intensity can destabilize already delicate systems and expose the brain to serious risks. The threat posed by corticosteroids can be summed up in three fronts: hypertension, hyperglycemia, and lipid imbalance. The first threat is their effect on blood pressure. Like anti-inflammatories, corticosteroids cause the body to retain sodium and water, but in an even more pronounced way. With more fluid circulating in the system, the heart is forced to work harder, and blood pressure rises. Often, this increase is gradual and imperceptible, only becoming evident after it has already caused vascular damage. And that is exactly what makes the brain more vulnerable to ischemic or hemorrhagic events. The second threat is elevated blood sugar. Corticosteroids increase blood glucose levels and reduce the effectiveness of insulin. In many cases, this leads to a condition known as steroid-induced diabetes, something many people are unaware of. And what does this have to do with stroke? Everything. High blood glucose damages the inner walls of arteries, accelerates plaque formation, triggers inflammation, and increases the risk of thrombosis. Excess sugar circulating for days or weeks acts like a corrosive acid on the brain's blood vessels. The third threat is metabolic. Corticosteroids alter cholesterol levels, increasing LDL, the so-called bad cholesterol, and decreasing HDL, which helps clear arteries. They can also make the blood more viscous and dense, making it easier for clots to form. The result is a perfect storm for a stroke: narrowed, inflamed arteries under pressure, with thickened blood and high sugar levels, all at once. That's exactly what happened to Jorge, a 72-year-old patient with COPD, chronic obstructive pulmonary disease. 4 years, during every respiratory flare-up, he received cycles of prednisone. The medication helped him breathe and brought relief. But no long-term reduction plan or alternative strategy had ever been established. Over time, Jorge developed mild hypertension, his blood sugar hovered near the upper limit, and his cholesterol became unbalanced. One afternoon, while reading the newspaper, he noticed the letters blurring and felt tingling on one side of his face. The diagnosis: ischemic stroke. Prednisone wasn't the sole culprit, but it was the constant fuel that accelerated the collapse. So how do we deal with a medication that is so necessary, yet so potentially harmful? The answer is caution and planning. The first step is to speak with your doctor and reassess the true need for continuous use. In many cases, there is the possibility of reducing the dose, increasing the intervals between cycles, or switching to other medications with less systemic impact. For those with asthma or COPD, for example, the use of inhaled corticosteroids may offer good inflammation control with much lower cardiovascular risk. Another essential step is the active monitoring of side effects. Blood pressure, glucose, and cholesterol must be checked regularly. Diet must be adjusted. Sodium intake should be drastically reduced, simple sugars eliminated, and fats managed with care. Light physical activity can also help offset the negative effects of corticosteroids. The goal is simple: if corticosteroid use is unavoidable, everything else around it needs to be protected. A very common mistake is treating corticosteroids as an isolated treatment, when in fact, they require a complete support plan to protect the body, especially the brain. The cost of ignoring these side effects can be far too high. That's why knowledge is so important. You don't have to give up the treatment, but you do need to know where it's taking you. And with that understanding, you can make safer decisions, have better conversations with your doctor, and protect yourself from silent but severe consequences. Among all the medications that increase the risk of stroke in older adults, there is one group that must be addressed with special caution: antipsychotics. Drugs like risperidone, quetiapine, and olanzapine were originally developed to treat severe psychiatric conditions such as schizophrenia or manic episodes in bipolar disorder. When used for those purposes, under strict control and close monitoring, these medications can be life-saving. However, the problem begins when they are used outside of this original context, especially in managing behavioral symptoms in elderly patients with dementia. Unfortunately, what we see in clinical practice and behind the scenes in long-term care facilities is a growing, and deeply concerning, trend of prescribing antipsychotics to patients with Alzheimer's or other dementias simply to calm them, control agitation, or make caregiving easier. It's understandable that managing challenging behaviors like aggression, delusions, or nighttime confusion can be overwhelming. But resorting to antipsychotics as a first-line response can come at a high cost. Literally, it can cost a life. Leading regulatory agencies such as the FDA in the United States and the EMA in Europe have issued the strongest possible warnings against the use of these drugs in elderly patients with dementia. This is known as a black box warning, a prominently displayed alert on the drug label stating that the risk of death is significantly increased in these cases. One of the leading causes of this increased mortality is stroke. Studies show that the use of antipsychotics in elderly dementia patients can nearly triple the risk of stroke. This is not a minor variation. It's a statistical leap that demands immediate attention. The mechanisms of harm are multiple. First, there's orthostatic hypotension, a sudden drop in blood pressure upon standing, caused by these drugs. This instability can lead to fainting, falls, fractures, and most importantly, momentary oxygen deprivation in the brain. Repeated over time, this can trigger a stroke. Secondly, antipsychotics can disturb heart rhythm, leading to arrhythmias that may generate clots. If these clots travel to the brain, they block blood flow and cause irreversible damage. In addition, these medications have profound metabolic effects. They raise blood sugar levels, increase cholesterol, promote weight gain, and make the blood more viscous. In just a few weeks, a patient may develop a profile resembling metabolic syndrome, a direct and powerful risk factor for cardiovascular and cerebrovascular diseases. Let me share with you the case of Elena, an 80-year-old woman diagnosed with moderate-stage Alzheimer's. She was a sweet lady, but in recent months had begun experiencing episodes of restlessness and irritability. Her son, concerned, sought help from a doctor who prescribed a low dose of risperidone. Within days, Elena became visibly calmer, but also more drowsy, less engaged. She spent most of the day sleeping. The family, relieved by the absence of agitation, failed to notice the warning signs. Until one afternoon, Elena was found with a drooping mouth, unable to speak. She had suffered a massive stroke. Her already vulnerable brain couldn't withstand the combination of low blood pressure, altered heart rhythm, and increased blood viscosity. Situations like this demand serious reflection. The prescription of antipsychotics to elderly patients with dementia should only be considered as a last resort, when all non-pharmacological strategies have failed and the patient's behavior poses an immediate risk to themselves or others. Even in such scenarios, their use should be temporary, closely monitored, and accompanied by a clear plan for gradual withdrawal. Yes, there are safer alternatives. The first step should always be to investigate the root causes of agitation. Often, the elderly person is experiencing pain, discomfort, a urinary tract infection, hunger, cold, sensory overload, or even loneliness. Behavior is a form of communication. Before silencing that signal with heavy medication, it's essential to listen carefully. Behavioral strategies, such as establishing a predictable routine, reducing noise, using familiar music, simplifying tasks, and maintaining a calm environment, are far more effective in the long term and infinitely more humane. As a doctor, I know this requires time, patience, and dedication. But I also know that preventing a stroke or a prolonged hospitalization is worth every minute invested. If you care for someone with dementia, or if a professional has prescribed an antipsychotic to a loved one, it is your right and your responsibility to ask questions. Ask, is this truly the only option? What alternatives have been tried? Is there a plan to taper this medication soon? These questions save lives. What's at stake here is not just the risk of a serious medical event. It's the preservation of dignity, autonomy, and the clarity that still remains. It's about protecting what can still be lived with quality. Chemical sedation may seem like a quick solution, but in many cases, it is the beginning of irreversible loss. Choosing the harder but safer path is an act of courage and of love. After so many years accompanying patients through different stages of life, I can say with absolute certainty, there is nothing more valuable than knowledge applied at the right time. Today, we walked a difficult but necessary path together. We opened the medicine cabinet that many maintain out of habit, routine, or prescriptions from years past, and shed light on dangers that, unfortunately, are still rarely discussed, even among healthcare professionals. We talked about non-steroidal anti-inflammatory drugs, like ibuprofen, diclofenac, and naproxen. Popular medications that can silently raise blood pressure, damage the kidneys, and increase the risk of clot formation. Then we examined anticholinergics, frequently used to control urinary incontinence, but which directly interfere with acetylcholine, impairing memory, cognition, and even cerebral circulation. We also addressed systemic corticosteroids, such as prednisone, which, while necessary in certain conditions, alter blood pressure, blood sugar, and lipid levels, and can become a metabolic bomb for the aging brain. Finally, we discussed antipsychotics, whose inappropriate prescription for elderly individuals with dementia represents one of the most serious, and least discussed, threats to neurological health in old age. But this content wasn't created to cause fear. It was created to give you back control. For many years, medicine was built as a one-way street, where the doctor spoke and the patient simply obeyed. Today, that model is outdated. An informed patient is a protected patient. You are not here just to take medications. You are here to understand what they do, how they work, and what consequences they bring to your body and mind. Because only with that understanding can you make truly conscious decisions. The most important step now is action. Don't wait for symptoms. Don't wait for something to happen. The ideal is to calmly and carefully review all the medications you or your parents, grandparents, or those in your care are taking. Identify whether any of them belong to one of these 4 groups. If so, schedule an appointment with the prescribing doctor. Bring information, ask questions, express your concerns clearly, respectfully, but firmly. You can say, I've been reading about the risks of certain medications in people my age, and I'd like to better understand the pros and cons of what I'm taking. That conversation can be the turning point for your health. Remember, the goal is never to abandon treatment, but to adapt it to your current reality, to your body today, to your brain's vulnerabilities at this stage of life. Many medications, when properly indicated and monitored, remain useful. The danger lies in long-term, indiscriminate use, or failure to review them regularly. Aging demands adjustments, and the aging brain requires special attention. Your brain health cannot be treated as a detail. Stroke doesn't choose a time, nor does it give a warning. It strikes when the ground has already been prepared, silently, by daily choices. But the good news is that this ground can also be undone. Every conscious choice, every behavior review, every well-guided substitution, every open conversation with a health professional is a step toward prevention. And if you have an elderly loved one, someone who depends on you, remember that they might not have access to this information. They may trust old prescriptions blindly, not realizing that their body has changed, and that the risks have increased. Be their protective link. Help find alternatives, update treatment approaches, raise questions. Not out of distrust, but out of love. The brain is the center of our identity. It holds our memories, our language, our emotions, our story. Protecting it is preserving who we are. And that's why everything we've talked about today matters so much. You now have tools. You have arguments. You have a scientific foundation. And more than that, you have the right to make responsible decisions. If this message resonated with you, if it brought clarity, if it raised questions, don't keep it to yourself. Share it with someone who needs it. Send it to a sibling caring for your parents, to a friend who's mentioned strange symptoms, to that acquaintance who takes daily medications without fully understanding why. Quality information should not be a privilege. It should be a safety net. And if you're willing, share your story. How many times have you taken one of these medications? Have you talked to your doctor about them? Have you experienced side effects? Hearing how others are navigating similar situations helps strengthen all of us. In this way, we create a community of care, awareness, and empowerment. Thank you for your attention. And remember, you are not just a patient. You are the conductor of the orchestra of your own health. Take care of your brain. It's the only one you have.